Professor, Department of Pharmaceutical Analysis, PhD College of Pharmacy, Coimbatore. I kindly invite the chairperson, sir, to introduce the speaker of the session. Sir, please.
Good morning, everyone. It's my privilege and I feel so honored to introduce my teacher and the eminent speaker to the gathering. Sir, I feel so obliged in introducing you, sir. So kindly bless me and wish me to introduce you to gathering. Sir is my teacher. It's my so privileged to introduce sir. So let me continue with this brief profile. Dr. Rajalingam sir, Associate Professor, Department of Pharmacy Practice, College of Pharmacy, Ramakrishna Institute of Paramedical Sciences. Sir have completed his B.Pharm in the year 1994 at JSS College of Pharmacy, OT, M.Pharm in the year March 1996 at JSS College of Pharmacy. He has continued his PhD in the year April 2012 at the College of Pharmacy, Ramakrishna Institute of Paramedical Sciences. He is having a teaching experience of 25 years. He started his career as teacher, as assistant professor in RBS College of Pharmacy, Coimbatore. Then continued his service with Ramakrishna Institute of Paramedical Sciences as assistant professor and now being associate professor. He has guided around 30 research works for PG students, the Department of Pharmacy Practice in Sutix, and 10 research works for PharmD students and 15 research works for B.Pharm students. He has published around 25 papers in national and international reputed journals. He is currently the program officer for NSS in the Institute of Ramakrishna for the past 8 years. He is member of PG board studies in Kerala University. He has been a practical examiner and question paper setter for various universities and colleges. And he served as member Scientific Service Committee in IPA for a period of 3 years. He served as member Scientific Service Committee for IPA National Convention in the year 2009 and 2012 and also in the year 2010. He is being a editorial member of Journal of Young Pharmacists and for the newsletter of his department. He is a lifetime member of Tamil Nadu State Pharmacy Council and All Indian Association of Pharmacy Teachers of India. He is being an inspector in Pharmacy Council of India and he has delivered invited talk in patient outcomes and medication in several gatherings. So with this kind note, we are seeking for your excellent words, sir. I hand over the session to you, sir. Thank you.
Thank you, sir. Start the session.
Thank you, Mr. for your introduction and overwhelming. A very good afternoon to all the participants who are assembled here. I think after one session in the first 3 days, I hope your mind is fresh to listen to my talk on the topic medication safety leader, roles and responsibilities of pharmacists. I understand that majority of the students are in the verge of completing their pharmacy or maybe a budding pharmacist, especially some of them are PharmD professional. So I am not going to talk anything very advanced. Maybe the topic slightly may look or it is quite new for some of you who is a medication safety leader. Every individual is going to complete pharmacy course. Once if they get into the practice, probably after a few years of their service in the practicing part, can become a medication safety officer. So let me get into the topic without much delay. Primer non-auxiliary. It looks something like Greek and Latin. Of course, it is actually Greek word it is, which specifically says first let us not do any harm to the patient. That is the idea behind any healthcare provision. Let it be any healthcare provider. We are not supposed to do any harm to the patient. That is what is mentioned in Greek. And this is not a term that I have developed up. It is there in the Hippocratic concept of Hippocratic oath. It is there in the year 460 to 370 BC. He has created a oath, and even worldwide, the medical professionals are sticking to the Hippocratic oath. The meaning of this is, the oath does not have this word that I do not do any harm, but the concept of Hippocratic oath is doing no harm to the patient. So this is a very big responsibility that every individual who is in the front of healthcare provision need to understand. It's something like an ethics. When you start from your home to join a college, there is a basic advices from your parents and grandparents. ஒழுங்கா போப்பா, ஒழுங்கா படிங்க, நல்லா சாப்பிடுங்க. அந்த மாதிரி ஒரு பேசிக்கான ethics is that I should not do any harm to my patient. Let it be doctor or a nurse or a physiotherapist or a pharmacist. Anybody, when I try to deliver my care to them, it is that I should not harm anyone. And as you all know, that drug is a double-edged sword. The same way, when doctors are trying to provide treatment, either it is pharmacological or non-pharmacological treatment, in case of surgery or anything, there are possible that they can do harm with the surgery procedures or any other process in which they provide health care. So that time there is a chances that you are able to create a harm to the patient. But again, you have to remember that you are not supposed to harm the patient, and also we should accept that we are not immune to harming the patient. Nobody is like that. Yes, I am 100% sure that I will not harm any patient. So that is how the concept is started, and all the healthcare professionals need to make the patient understand. See, when we talk about healthcare provision, you have to remember one thing is that you also have part of it. You, in the sense, I am talking about the patient. I have a healthcare team, and that team has to include the patient also into it. And so very important is you have to make the patient understand that there are certain harm that is being created by the process of healthcare provision. So that is another important point, that there is no possibility that I can provide you kind of treatment without harming the patient. Maybe the extent or the gravity of the harm created or the magnitude of the harm created is varying from one patient to the other. So patient safety must be the primary focus for every practicing pharmacist and organization within which the person is practicing. So I'm getting slowly into the topic that I'm very specifically talking about the pharmacist. So you have to always have the patient safety in the mind. I don't know, many of you might have started talking about pharmaceutical formulation. When we try to develop a formulation or discover a new drug or invent a new drug, we may not exactly look only into the effectiveness of the drug. Is there anybody who says, yes sir, I take this drug, it is 100% effective, and come up with a point solver, but I am not very sure after taking this drug you will be alive. The mother சாப்பிட்டா நோய் போயிடும், ஆனால் நீங்கள் உயிரோடு இருப்பீங்கன்னா, whether you will be taking the medication? No. The other side is you can take any amount of the drug, nothing will happen to you, but the effect is very less. So there should be a balance is required between the safety and effectiveness of the drug. Many times we will be looking more into the effectiveness in terms of drug discovery or drug development or formulation development. When it comes to the profession of pharmacy practice, we will be more looking into the patient safety, whether how the drug is going to harm the patient or how I can prevent the patient from getting the harm. That is the role that I will be seriously looking into it. Maybe the recent trends in the healthcare system, like the accreditation systems are looking more into the patient safety aspects. So actively managing the medication safety is therefore both the professional responsibility and moral and ethical principles. So on both the grounds, see sometimes there is a concept called as risk to benefit ratio. When we talk about risk and benefit, there is a drug which may not be safer to the patient, but at times we have to take the risk in order to save the patient. We can save the life, but there should be some kind of risk is involved. When I manage or I calculate or analyze what is the benefit that I am going to get over the risk. So that is the role of a medication safety officer. So I have to first look into the patient safety. So before getting into the actual topic of medication safety officer, I would like to highlight upon what is what are the threats for patient safety. So to harass human, இது வந்து ரொம்ப காமனான ஒரு சென்டென்ஸ். ரொம்ப வருஷமா நம்ம தமிழ்ல எல்லாம் கரெக்டா சொன்னா தப்பு செய்யறது வந்து ஒரு சாதாரண இயல்பான ஒரு விஷயம். But how the mistake is being measured is depending on the outcome of it. And immediately இன்னொன்று சொல்லிடுவாங்க இல்லையா, தப்பு செய்யறது எப்படி இருக்கோ அதே மாதிரி அதை வந்து forgive பண்ணி போயிடும், மன்னிச்சுட்டு போயிடணுங்கிறது is a common status. So that is to forgive is divine. This is very important status in terms of patient safety, but we cannot ரொம்ப டிவினிட்டியா நம்ம போய் அந்த தப்பெல்லாம் மன்னிச்சுட்டு போயிட முடியாது. But at the same time we cannot take a sue them, take a punishment. That all is not possible. But what is expected from an healthcare system is you have to build a safer health system. So as a pharmacist or budding pharmacist, after getting into the practicing profession, you will be working towards building a safer health system for a patient. So this is why I am talking about. This is a very only a small portion. I can say a tip of an iceberg. That is around 1 in every 10 patients is harmed in healthcare. It is not visible for us, but you can take it. Sometimes it looks like slightly exaggerated. Hospital for a patient or harm create ஆகுது. That harm could be either by use of medication or by the way by they are getting treated. But this is true. But Indian setup, we do not have much data on patient or medical errors. And there are 3 million deaths occur annually due to unsafe care, especially in low to middle income countries. We are claiming that we are moving to a superpower status. We are becoming well-developed country. We are having very good healthcare system, but still we are not having any system on accountability for such kind of errors. There are certain documentations are there on the newspapers which says that there are about 5.2 crores of medical errors are happening in India, and 80% of them are errors which are accountable for surgical errors. So many times we do not really know what error exactly is happening. And about 50% of the harm that is created to the patient is preventable. So this is the point that you have to understand, the error which can be prevented. That is very important. So if we start working towards preventing these errors in an effective manner, I think you can increase the safety profile for the patients. And some estimates suggest that as many as 4 in 10 patients are harmed in outpatient setting, and 80% inside the hospital are being affected. So when I talk about medical errors, I am not talking about medication errors. Are you able to differentiate medical and medication? Medical error is any error that happens inside a provision of a healthcare. Medication error is one particular area where the error or the harm created by the drug that is being used. So if you look at these areas, so common One, adverse events. Adverse event is the event which is not pleasant, the event which is not expected. நான் டாக்டர்கிட்ட போகிறேன், சர்ஜரி பண்ணோம், நம்ம சினிமாவில் நிறையா பார்த்துருக்கலாம், பட் ரியல் டைமில் ரொம்ப கம்மியாக தான் பார்த்துருக்கோம். ஆப்ரேஷன் வந்து வயிற்றில் பண்ணணும், கண்ணில் பண்ணிடலாம், ரைட் வயிற்றில் பண்ணணும், லெஃப்ட் லெக்கில் பண்ணிடலாம். இதெல்லாம் நம்ம வந்து சினிமாவில் பார்க்கும்போது ஒரு காமெடியாக கடந்து போயிடலாம். பட் தீஸ் ஆர் திங்ஸ் விச் ஆர் ரியலி ஹேப்பனிங் இன்சைட் தி சிஸ்டம். ஸோ அந்த மாதிரி இஃப் யூ கால்குலேட் or if you look into the categorization of such error, the first error which is highlighted is your medication error. The error that is caused by the use of medication and unsafe surgical procedures. The procedures that are being followed inside the theatres are not safe. Healthcare associated infections. These are another set of problems where this can be otherwise called as nosocomial infection or hospital acquired infection. Patient 10 நாள் நல்லா தான் இருந்திருப்பாரு, ஹாஸ்பிட்டலில் 10 days இருந்திருப்பாரு, கிளம்புற சமயத்தில் பார்த்தா திடீர்னு ஒரு இன்ஃபெக்ஷன் வந்துடும். என்ன ரீசன் பார்த்தீங்கன்னா, he would have picked up infection from the hospital, and this is also one kind of error. And there are programs which have to control these kind of hospital or healthcare associated infections. Diagnostic errors, patient falls, pressure ulcers, patient misidentification, unsafe blood transfusion, or these are the probable medical errors that can cause harm to the patient. And this patient harm potentially reduces the global economic growth by 0.7%. The reason is very simple. When there is a harm created, in order to treat the patient for the harm that is being created, you have to additionally spend some time. You have to additionally spend some money on the drug. So that is 0.7% per year in the global economic growth. So 0.7% coming up. I am talking about the statistics that are available. They are available statistics, and in the developed countries, very few developed countries only has this statistics, and around 200 countries in the globe, and around 10 to 20 countries are only developed nations, and remaining 100 countries are developing nations, and underdeveloped countries where you do not have any such data. So even this 0.7% would grow even bigger. The amount is very high. நீங்க பாத்தீங்கன்னா நம்ம ஊர்ல ஒரு ஸ்லோகன் ஹெல்த் இஸ் தமிழ்நாடு கவர்மெண்டோட ஹெல்த் டிபார்ட்மெண்டோட ஸ்லோகன் அந்த ஹெல்த் இஸ் வெல்த். That is the reason many times when we fall sick we have to spend more on the health care system. So the indirect cost of harm amounts about trillions of US dollars. This is what the 0.7% is, and how we can bring up bring down this cost is by investing on programs, technologies that can minimize the patient harm. So this is about medication error. Since we are the pharmacists, I will be going through in detail about the medical errors. Medication error. There I will be discussing about, and surgical errors. As I told you, there are a lot of errors, but this we are not aware of because we are not trained for doing any surgery, or we are not permitted to be there inside the surgery. So we do not know what kind of surgical errors, or I have not explored any chances of it. But there are 80% of errors are accountable for surgical procedures. Maybe it is unsafe surgical procedures. For us as a pharmacist, we have a limitation where we can make sure that the patient is being properly prophylactic doses are being given before starting of any surgery, depending on what type of surgery it is. The surgeries can be broadly classified as contaminated surgery, clean and contaminated. So depending on what type of surgery it is, the type of antibiotic to be given as a prophylactic before the start of surgery. What time the antibiotic has to be given, what is the type of antibiotic, how much has to be given, and how long the surgery will be continued, and if it is required, one more dose during the surgery has to be given. So all this only we can do it, and beyond that, if something goes wrong with the procedure, that will be categorized under surgical errors. And as I told you, healthcare associated is nosocomial infection, where we have again a clear role how we can prevent it. One classical example, now current trend is talking about antibiotic stewardship. Antibiotic stewardship is what is the correct antibiotic, how much to be given, and when to given, and when to stop about it. Because ரொம்ப short time ல வந்து drugs are getting expelled out of the market. There are no use of it. 1940s லாம் we have invented penicillin. That is considered to be the magic bullets. Second World War ல தான் they have accidentally identified penicillin notatum, from which you extracted penicillin, and from there you were you started treating all kind of infections, right? But within a period of 80 years, whatever the antibiotics that we have is not going to be very big use, because a very irrational use of antibiotics are there. Especially in country like India or developing nations, the use of antibiotic is not much taken care. நீங்க இன்னைக்கு உங்களுக்கு உடம்பு சரியில்லை, ஒரு மாதிரி 2 வாரம் கோல்டா இருக்கு அப்படின்னு என்ன பண்ணுவீங்க? டாக்டர் போகுமாங்களா? I don't think we will go to a doctor. நமக்கு கொஞ்சம் ஐடியா இருக்கும், இல்லை அப்படின்னா we go to a community pharmacy. மருந்து கடைக்கு போயிட்டு அந்த பக்கம் இருக்கவர் யாருமே தெரியாது, ஆனால் அவரை நம்புவோம் நம்ம. You believe அந்த பக்கம் இருக்கவர் ஒரு 10th standard படிச்சவராக இருக்கார், but you believe them and you ask for some medicine and they will give you. Definitely 80 to 90% of the time you will be given with an antibiotic. The antibiotic or full course சாப்பிடணும். Definitely no medical shop is going to advise you a full course of medicine. ஒரு 3 டோஸ் சாப்பிட்டீங்கன்னா டெஃபினட்டா ஒரு இன்ஃபெக்ஷன் இருக்கு, ஒரு பாக்டீரியல் இன்ஃபெக்ஷன் இருக்கு, ஒரு ஆன்டிபாக்டீரியல் சாப்பிட்டீங்க அப்படின்னா ஒரு செகண்ட் டோஸ்ல you will start feeling the relief. இன்ஃபெக்ஷன் குறையிற மாதிரி ஒரு ஃபீல் இருக்கும். 3வது டோஸ் சாப்பிட்டதுக்கு அப்புறம் சரியா போச்சுன்னு சொல்லிட்டா you will stop taking that medication. That will increase the resistant pattern for a particular organism, and that has lead now we do not have a correct medications. Still we are not able to eradicate tuberculosis. TB remove பண்ணியாச்சா, polio பண்ணியாச்சு, என்னென்னமோ infection disease பண்ணியாச்சு, ஆனால் TB we are not able to eradicate. ஃபர்ஸ்ட் ஒரு வேக்சின் கொடுத்தாங்க இல்லையா? என்ன வேக்சின்? அது கண்டுபிடிச்ச வேக்சின் பார்த்தீங்கன்னா BCG வேக்சின், which is given for TB. But still we are struggling to eradicate TB from our population. The reason is because of the irrational use of antibacterial substances. So that is more related with healthcare associated infections. Sepsis is very common. If it is not treated, the infection will enter into the systemic circulation. This probably comes under medical error. So that is also one reason why patients get harmed. Diagnostic error by mistake, they may not identify properly, so the treatment would have been not correct. Patient falls. This is again not only by age the patient falls. Patient fall is very common in elderly patients. Patient fall is very common in elderly patients, not for adult or old adult. How this fall happens is not only because of age factor, but other side, the drugs that are inappropriate for elderly patients. நம்ம இதுவரைக்கும் பார்த்தீங்கன்னா இந்தியன் செட்டப்ல I don't find anywhere an exclusive geriatric department. எல்லா ஹாஸ்பிட்டல்லையும் pediatric department இருக்கும். குழந்தைகளை ட்ரீட் பண்றதுக்கு definitely there will be a treatment department for it, but there are no hospital in recent time that come with geriatric department. Very recently in state of Tamil Nadu in Chennai, they have opened a hospital exclusive for geriatric care. But otherwise, geriatric care is not much popular in Indian setup, where they prescribe any drug which is common for even adults. So out of this, I can say about 30 to 40% of the drug which normally the same patient had taken when he or she is in adulthood. But the same drug, when it is being given after the age of 65, they are not supposed to be appropriate for them. So in that case, what happens is this type of problem. Example I can give you is benzodiazepine. Benzodiazepines are very common in elderly patients, and when it is being given to them, it produces fall for them, and due to this fall, there is kind of fracture and extended hospital stay. So that error for the patient fall is again considered as a medical error. Venous thromboembolism, this is again not in our review. Unsafe transfusion practice, pressure ulcers. And what are the reasons why these harms are created or is there prevailing in patients? One is the system and organizational factor, where the complexity of medical intervention, inadequate process and procedures, disruptions in workflow. If I ask you as a student why you are not performing better, a teacher comes to you and gives you a work and you are supposed to submit within a week. Maybe all the teacher comes to you in your class, gives you an assignment and expect them to submit within a week of time, and you will feel overburdened, right? Workload கொஞ்சம் ஜாஸ்தியா இருக்கறதுனால you will not be able to perform very well. So the system you to patient harm by means of some other reason, one or the other way they may create a harm to the patient. And technological factor, where again I can give you that improper diagnosis. Maybe the person who is in the technician or the doctor who is trying to understand the radiological process does not predict it properly, or the machinery involved in the process of diagnosis is not giving you perfect results. Maybe you go to a clinical lab, take your blood sugar value, you are 18 to 20 years old, you are not diabetic, but all of a sudden it shows you that you are having diabetic. Immediately you get a doubt or not. How come I am getting diabetic? So you will ask for one more time, or you will try to change the mechanism. So that type of errors are reason is technological factors. And human factors and behaviors. This is very common. In the error வந்து பாத்தீங்க அப்படினா எல்லா பக்கமும் any system, not only in medical system, உங்க காலேஜ்ல எடுத்துக்கிட்டாலும் சரி, இந்த ஆர்கனைசேஷன்ல எடுத்துக்கிட்டாலும் சரி. We always in my institute in pharmacy practice department, whenever our PG students come, there would be an orientation class, and during that orientation class we used to tell a phrase. We can take the horse to the pool, and it is up to the horse to drink or not. It is for a student that we have all the resources, it is up to you, you have to take it. We also say that there is one difference between an animal and a human. என்ன டிஃபரன்ஸா இருக்கலாம்? என்ன டிஃபரன்ஸ் இருக்கலாம்? ஒரு அனிமலுக்கும் ஒரு ஹியூமனுக்கும். ஏதாவது ஜோக் சொன்னா நீங்க சிரிப்பீங்களா சிரிக்க மாட்டீங்களா? ஏதோ ஒரு ஜோக் சிரிப்பீங்களா சிரிக்க மாட்டீங்களா? நான் ஜோக்லாம் சொல்ல மாட்டேன் நான். ஏன்னா எனக்கு தெரியாது உங்களுக்கு என்ன ஜோக் பிடிக்குன்னு எனக்கு தெரியாது. நாங்கள் படித்த காலத்தில் நாங்கள் பார்த்த சினிமாவில் இருந்த ஜோக் பண்ணுறாங்க நிறைய பேர் இருக்கவங்க. ஸோ ஜோக்குக்கு சிரிப்பீங்க, ஒரு அனிமல்கிட்ட போய் ஜோக் சொன்னால் சிரிக்குமா? அது மட்டும் டிஃப்ரென்ஸ் இல்லை. உங்களுக்கு உடம்பு சரியில்லை அப்படின்னா மருந்து சாப்பிட்டா சரியா போயிடும் அப்படின்னு மருந்து சாப்பிட்ற ஒரு சென்ஸ் இருக்கு இல்லையா, சிக்ஸ்த் சென்ஸ் இருக்கு இல்லையா, that will not be there. That will not be there for an animal. So it is the patient. எவ்வளோ பேர் இங்கே கம்ப்ளைண்டாக இருக்கீங்க? நான் எப்பயுமே என்னோட ஸ்டூடெண்ட்டை கேட்குற கொஸ்டின் தான், ஒரு இன்ட்ரோடக்ஷன் கிளாஸ்லாம், how many of you would like to take medication? சில பேர் வந்து ஈட் மெடிகேஷன், சார் எனக்கு பிடிக்கும் சார், நான் அப்படியே கிராஸ் பண்ணிக்குவோம் சார், என்னோட ஃப்ரெண்ட் ரூமில் டைட்டின் டேப்லெட் இருக்கு, சும்மா நல்லா இருக்குன்னு எடுத்து சாப்பிட்டு போகலாம். சில சமயம் விட்டமின் சி சூப்பர் டேப்லெட் இருக்கும், எடுத்து சாப்பிட்டு போகலாம், ஒன்றும் பிரச்சனை கிடையாது. இதே மாதிரி எல்லா மெடிசனும் சாப்பிட முடியுமா? பட் there are people இப்படி தான் இருக்குன்னு சொல்லி எடுத்து சாப்பிட்றது ஒரு 5% இருப்பாங்க. இன்னும் ஒரு 50% of people எப்படி இருப்பாங்க, எனக்கு உடம்பு சரியில்லை, I have to take medication, but otherwise I am not taking any medication. இன்னொரு 40 to 45% இருக்காங்க. இல்லை இன்னொரு 10 to 20% இருக்கலாம். அவங்களெல்லாம் வந்து ஃபோர்ஸ் பண்ணணும். You have to compel them. ஒரு குழந்தைக்கு வந்து குழந்தைக்கு தெரியுமா மாத்திரை சாப்பிடணும் அப்படின்னு, you have to force them to take the medication. இன்னொரு 10% நீங்க என்ன பண்ணாலும் அவங்க வந்து they will not take medications. And the percentage நான் சொல்ற 10 to 20 is even it is more. Given a chance, I will not take medication. I am very sure if I take a survey from this hall, at least 20 to 30% will be having an intention that at any given cost I will not take medication. என்ன வந்து கையை காலை கட்டி போட்டு அப்புறம் மாத்திரை கொடுத்தீங்கன்னா சாப்பிடுறீங்கன்னா I will prefer not to take any medication. So this is a patient related factor. How I am going to take. கொடுத்த மெடிசனை கரெக்டா இந்த நான் சொன்னேன் உடம்பு சரியில்லைன்னா I will take medication. But if you look at the pattern of how they take medication, டாக்டர் ஒரு 5 நாள் கேள்வி கொடுத்தாருன்னா 2வது நாள் 3வது நாள் I stop taking medication. The third day I stop taking. வாங்க மருந்து என்ன வரும் வீட்டில் அப்படியே கிடக்கும். சரியா? இன்னும் நிறைய ஹேபிட் இருக்கு. நீங்க பாத்தீங்கன்னா டாக்டர்கிட்ட வந்து பிரிஸ்கிரிப்ஷன் வாங்கிட்டு மெடிக்கல் ஷாப் போனோம்னா என்ன கேட்பாங்க, இந்த மருந்தெல்லாம் இருக்கா சார் கேட்பாங்க. கரெக்டா எல்லாம் இருக்கு சார் அப்படின்பாங்க. சார் டாக்டர் 10 நாளைக்கு எழுதியிருக்காரு, 3 நாளைக்கு கொடுங்க, அதுக்கப்புறம் வந்து வாங்கிக்கிறேன். You think 80% of them will come again and take the medication? 100% will not. So this behavior is again going to create a chance for the patient becoming or getting the harm. And there are other external factors like absence of policies inside the organization or inside the country. There is no regulations. In the abroad countries, the western part of the world, there is a regulation for OTC medications. In the Indian setup, OTC medication, there is no exactly a regulation as being. Now they are in the process of creating it. But there are a few advertisements are there in the televisions and the screens, the social media, you get advertisement for some of the medications, which can be only possible if there is a OTC classes there. But in Indian setup, we do not have. Earlier it was Schedule K of Drugs and Cosmetics Act talking about OTC drugs, but in late 1970s, that you stamp the next person immediately என்ன பண்ணுவோம், either we say sorry, இல்ல நம்ம ஒரு சைடுல ஒரு சின்ன சேல் இருக்கு, இது தொட்டு கும்பிட்டு போயிடும், அதை தப்பு பண்ணிட்டோம் அப்படின்னு சொல்லிட்டு அந்த care கூட we do not give for medications. We do not bother about what medication, whether the patient is getting the benefit out of the drug. So the basic of my talk would be on one simple word I can say this: pharmaceutical care. We are not aware of what is pharmaceutical care, what level the care has to go. So that is what we are going to discuss. So there are few other factors from healthcare providers. We can make sure there is inadequate information about the patient. Patient ability we do not know completely. Inadequate information about the drug that is being prescribed. Communication and teamwork failures. Unclear or absent or look-alike drugs, labels and packages. இந்த கிளாஸ்லயே நடக்கும், 2 பேர் ஒரே மாதிரி இருப்பாங்க, பேரை மாட்டி கூப்பிடுவாங்க. அப்ப கன்ஃபியூஷன் வரும் இல்லையா? எங்க பிரின்சிபல்ட்ட கம்ப்ளைண்ட் பண்ணும்போது நான் ஒரு பேருக்கு இன்னொரு பேர் சொல்லிட்டேன்னு வச்சுக்கோ, ஐயோ பனிஷ்மெண்ட்லாம் கொடுத்துருப்பாரு பிரின்சிபல், இப்போ அப்பா அம்மா கூட்டிட்டு அப்படின்னா வந்ததுக்கு அப்புறம் சார் இல்லை சார் அந்த பேஷண்ட் அந்த பர்சன் தான். அதே ப்ராப்ளம் திஸ் இஸ் ஹேப்பனிங் இன் medical side, that is especially with the drugs. Look-alike and sound-alike drugs, and unsafe drugs standardization, storage and distribution. Storage of drug is very important aspect. நம்ம வீட்லலாம் drug எங்க ஸ்டோர் பண்ணி வச்சிருக்கோம்? எங்க வச்சிருக்கோம்? மேக்ஸிமம் டைனிங் டேபிள். நிறைய இடம் பாத்தீங்கன்னா காமனா பாத்தீங்கன்னா ஒரு டைனிங் டேபிள்ல, ரெஃப்ரிஜரேட்டர் இருந்தா ரெஃப்ரிஜரேட்டருக்கு மேல, டீ இருந்தா டீ ஷெல்ஃப் கீழே, இல்ல ஏதோ ஒரு ஷெல்ஃப்க்குள்ள. இப்போ ரீசெண்டா we are conscious that at least ஒரு பாக்ஸ்ல போட்டு அந்த பாக்ஸ் கொண்டு போய் எங்கேயாவது ஒரு ஷெல்ஃப்ல வைக்கணும். முன்னாடி அந்த அளவுக்கு there is no aware about how the drugs have to be stored. ஏன்னா 10 years முன்னாடி போனீங்க அப்படின்னா you cannot find medical shops with air conditioners. இப்போ வரைக்கும் rules and regulationல you want to start a community pharmacy, என்ன சார் உங்களுக்கு மினிமம் ரெக்வயர்மென்ட் கேட்டீங்கன்னா ஒரு 110 சதுரடி ரூமும் சரியா, ஒரு ரெஃப்ரிஜரேட்டர், எலக்ட்ரிக்கல் கனெக்ஷன் இருக்குன்னா அவங்க லைசென்ஸ் கொடுத்துருவாங்க. They don't insist on any air conditioner. Now air conditioner is very important, right? Those people in the closed room, it is difficult. So for medication storage is also equally important. Other than storage alone, it is mentioned on the label. And if you do not follow, again the stability profile of the drug is getting affected, which indirectly affects the safety to the patient. And environmental factors, staffing patterns, and do not support the safety. Inadequate staff orientation, ongoing education, inadequate patient education, lack of supportive culture of safety, failure to learn from mistakes. These are all common things. The pharmacist or healthcare professional, the student in Kottana, all these factors will be suiting everyone. So these are the factors. So we are humans and therefore we will make mistakes. I'm very தப்பே பண்ணதில்லை சார், இல்லை பண்ணவே மாட்டேன் சார் அப்படின்னு சொல்றது யாராவது இருக்குமா? No, it is not possible. The culture has been shifting over the last decade to focus how we can improve rather than blaming each other. The blaming is very common. Schools எல்லாம் பார்த்துருக்கீங்க, நான் பண்ணல இவன் தான் பண்ணான். இன்னைக்கு இருக்க கல்ச்சர் எப்படி இருக்குன்னா, especially when we talk about medical error, we are not supposed to blame any individual in the healthcare provision. Sir, இது தப்பு வந்து டாக்டரோட சார், இது தப்பு வந்து மருந்து கொடுத்தவங்களோட சார், இது தப்பு மருந்து அட்மினிஸ்டர் பண்ணவங்களோட சார். It is not that. It is we have to create an environment that whoever has done but how I am going to minimize the error that is happening in the culture. So the shift has led to success in many aspects of patient initiatives. So what is patient safety? Patient safety is defined as a freedom as far as possible from harm or risk of harm caused by medical management as opposed to harm caused by natural course of patient. The simple definition is naturally எனக்கு disease வந்துருக்கு, அந்த diseaseல வரக்கூடிய ப்ராப்ளங்கள் இல்லாம when I am under a medical treatment either by a doctor or a nurse or a pharmacist, I should not get harm because of the process, and that is what here we come to be patient safety. So these are certain informations that is published elsewhere in India. A few data. Delhi, you can find the doctor operated on use wrong leg. Newborn in Kolkata was given with the wrong injection. Nurses say this just by mistake. இதெல்லாம் வந்து நியூஸா படிக்கும்போது நமக்கு பெரிய பாதிப்பு இருக்காது, ஒரு பெரிய இம்பாக்ட் இருக்காது. சப்போஸ் யூ ஆர் தி மதர் ஆஃப் த பேபி, if the baby would have died, right, then what is the impact? நிறைய இடத்துல பார்க்கலாம், திடீர்னு பொதுமக்கள் வந்து ஹாஸ்பிட்டல் கூட்டு அடிச்சுட்டாங்க, டாக்டர் ரிட்டர்ன் பண்ணிட்டாங்க. இப்போ ரீசெண்டாக you can find found in the newspaper, the guy stabbed a doctor and because his mother was not properly treated. So I am not here to argue who is right or who is wrong, but there are incidences happening and we have to look equally into both of them factors, what is really correct or not. So the drug dispensing error, why I have specifically mentioned this, we pharmacists are responsible for dispensing error. A drug dispensing error on medical instances, which is seen more in children in private area. This is about a study that has been published. If you make randomly, you can find certain studies in Indian setup and that is being published. What are the goals for patient safety? These are goals actually. Identify patient correctly, improve effective communication, improve the safety of high alert medication. இந்த எல்லா கோர்ஸ்லயுமே பார்த்தீங்கன்னா as a healthcare professional, I would be looking into more of problems associated with the medication. High alert medication. What do you mean by high alert medication? A medication which can cause harm even in a slightly higher doses. Now, all of the senior students in Kerala, there is something called as drugs with narrow therapeutic index. 1 mg கொடுக்க வேண்டிய இடத்துல டோஸே 1 mg தான் இருக்கும். அங்க ஒரு 0.5 mg ஜாஸ்தி ஆயிடுச்சுன்னா எஃபெக்ட் இஸ் ஸ்மால். ஒரு 100% 2 mg I have given 2 mg dose, the patient is reacting in a different manner. So, 1 mg is just the when a dose is 100 mg, the quantity is not a matter. But when a dose is 1 mg, another 1 mg you are adding will be a different altogether. ILM medication examples are classical example is insulin. Insulin or disadvantage in treatment. Any anti-diabetic drug. You will get hypoglycemia. By mistake, if you are giving an overdose, patient will get into hypoglycemia. Hyperglycemia is better to manage, whereas hypoglycemia, the patient may lead to coma, and recovering them becomes very difficult. So, high alert medication also you have to make sure, and you are not able to see. Ensuring correct site, correct procedure, and correct patient surgery. This is related to the site, and the color is very different. Someone can read what is written in that yellow?
அந்த yellow color என்ன இருக்குன்னு வாசிப்போம்.
It is reducing the risk of the patient harm by resulting forms of falls and reducing the risk of healthcare associated infections. I have listed out certain conditions where the patient may get harm. So these are all areas where you have to really focus, and this is being prescribed by WHO. So getting closer to the topic, what is adverse event? As I told you earlier, an injury caused by a medical management. I am not talking about any drug. It is the entire medical management, and it is called as adverse event. And there is another term which is very familiar, or we need to be familiar with, adverse drug events. Adverse drug event is a response to the drug. I think yesterday you had 2 sessions on adverse drug reaction.
Yes, sir.
So it is not an intentional action; it is an unintentional side effect of the drug that happens in a normal dose. So this is related with adverse drug reaction is related with the drug, whereas adverse event is not only with the drug, maybe because of the procedure. So this is very specific about medication errors. Like ADR, I am not going to talk much on ADR. I am going to talk more about medication errors. So when we talk about medication error, it has a very big circle. That is, there are more number of errors, out of which all the medication errors having a chance to become a potential adverse drug event. It is not that all the medication errors are harmful. There are certain medication errors which are not harmful. That's why I mentioned there are few percentage of medication errors are potentially unsafe, and there are few medication errors that are adverse drug events which can be prevented. So I am telling you, this is an area where we have to seriously look into it, because this medication error, if you believe, what could be the highest reason why patient death occurs? Natural or other means of a patient dying, what could be the reason? In the reason the patient sarlam.
Disease.
If I rate it, okay, let us take it as disease. Any disease would be more common because of this patient is getting dying.
Problem.
Cancer, cardiovascular diseases. If you start listing, you will get different types of diseases. And third highest number of death that happens because of medication errors, especially the errors that can be prevented. You imagine a patient getting a cancer and dying because of cancer. It is not enough cancer. You can provide treatment and you can make them sustain their life. If the patient is getting a block in this carotid artery, you can treat them, you can sustain his life. He is getting an infectious disease, treat them and rescue from his death. But a condition where the patient is very well in your control, You could have even prevented the death, but I didn't do that. And that has become the third highest reason the patient is dying. So it is our responsibility that we have to bring down that number. அது அந்த லிஸ்ட்ல இருக்கக்கூடாது, டாப் 100 குள்ள இருக்கக்கூடாது. So if we start working in avoiding these kind of interactions, I'm not saying that this should present. No, now at least we should work on how to avoid this preventable areas. Right, this is how the medication error is being categorized. Maybe the same way it is. So medication error is by definition is a preventable adverse drug event, however may or may not result in actual or potential drug events. So as I told you, it's not all the medication error is harmful, whereas adverse drug reactions are inevitable. Nobody knows when I am taking the drug for very first time whether I get the reaction or not. Nobody knows. So if you are taking the drug and you have to produce the reaction, nobody can prevent for the first time. Maybe second time you are getting exposed to the same drug and same effect, then that time it is preventable. So medications error are generally just a preventable drug error. So medication use has become very common. You go to any allopathic hospital and treating the patient with medication is very, very common. Around 90 to 95% of the patients are being treated with drug, one or more drug. So I say that I take surgical procedures or I use counseling procedures or physical therapy. Even then, there will be one or more drug will be involved in addition or to support the therapy which is given. For instance, I was telling you about surgery. Surgery is I cut, I open, I put sutures, the treatment is over. No, there is a drug involved, surgical prophylaxis, medical anesthesia, all are drug involved. So majority of the drug treatment is there in the allopathic hospital, and when you use drug, it is more complex. So it is very important that how to handle it. And medication error is a major cause of preventable patient now. And as a future healthcare workers, you have a very crucial role in preventing these medical errors. You here, I mentioned the pharmacist as a very crucial role in preventing this. So this is the statement which I already given you. It's a very popular statement. Some 24 years before this statement was used to understand the impact of medical error. See, I am here. 98,000 people are affected every year in America. So all these data are talking about these errors in countries like US or UK, where the medical system is developed. And it is still developing. They are coming out with or evolving with more new technologies. அங்க பாத்தீங்கன்னா areas and medication errors are very well prevented. அங்கேயே இவ்வளோ number of deaths இருந்தா, again we do not have any statistics, we do not have any monitoring procedures. I can tell you, maybe after the era of accreditation for hospital by NABH, there is an effective role for clinical pharmacists. Until then, there is no role for any pharmacist. Recently, I started having a feeling that who has been honored after Corona? யாரெல்லாம் தூக்கி வச்சு கொண்டாடுனாங்க கொரோனா? Inevitably doctors வந்து we cannot blame. அதை தாண்டி வேற யாரெல்லாம் கொண்டாடுனாங்க? Nurses, pharmacists, I doubt.
Shops.
But again, they don't inclusive நம்மள கொண்டாடு. We have not been considered into a healthcare profession. As sir said, that is, we are the one who have been given permission to run the shop 24 hours without any problem. So many times pharmacists were selling not only drugs, sometimes vegetables, sometimes meat, fish. அப்ப பாத்தீங்கன்னா எல்லா groceries வந்து எல்லாமே you can get it from the pharmacy. I'm just telling you the right part of it, but we are not being recognized much by the community. இன்னைக்கும் தெரியல இந்த சிச்சுவேஷன்ல நான் பெருசா மாற்றம் வரல நினைக்கிறேன். When you go and tell your friends that I am joining for BPharm, என்ன ரெஸ்பான்ஸ் இருக்கலாம்?
They ask BCom.
They either say, oh, it's BCom, or otherwise, if they don't understand what is pharmacy, probably they will say, okay, you are a person who will be sitting and writing accounts in your medical store. I'm talking somewhere about 40 years before, maybe now slightly the situation has changed. That time it was only 7 institutions in Tamil Nadu, now it is 100 institutions. So the majority would be knowing what is at least pharmacy is. But still, there is a long way that we have to go to get a recognition by the common man that they are also people who is working for us. Yes, because many times we work behind the scene. Indian setup every room setup we are producing pharmacists more for industry. Industrial work பண்றவங்க யாருக்குமே தெரியாது. ஏன்னா அவங்க கம்பெனிக்குள்ள போனாங்க 8 நாள் 10 நாள் அவங்க என்ன வேலை பண்றாங்கன்னு யாருக்குமே தெரியாது. Only if you are there working in a hospital. Maybe early 2000 where Tamil Nadu Dr. M.G.R. Medical University has brought a course called as pharmacy practice in M.Pharm. The real clinical pharmacy setup has started establishing. Maybe after the induction of PharmD program, it has taken a better shape. I think now seriously many corporate hospitals started looking into the clinical pharmacist. I can proudly say many of our clinical pharmacy practice students or PharmD professionals have worked in big hospitals where the prescription will be dispensed only after the approval of the clinical pharmacist. I was not even able to realize that a situation has come into India like that. But not everywhere, not every hospital. Only hospital who goes for accreditation will really try to have at least 1 or 2 clinical pharmacists, try to follow the procedures which is being given into that. So a long way to for a clinical pharmacist to go, and where especially you can take a lead in prevention of this medical errors. So the same 1.5 million hospitalized. They say every patient who is getting admitted in the hospital will definitely have at least one medical error, one medication error. And that error chances will be increasing with many other factors like age, number of disease condition, number of drugs being taken, how long the patient is staying inside the hospital. So with all these factors, you can understand that the problem associated with the drug is going to increase. If this patient is going to be a polypharmacy patient, which means the patient is prescribed with more than 5 drugs at a given time. So there is no prescription. There was a time where it has happened. During Corona, government was announcing, advertising, please do not take any other medication other than paracetamol because they are not going to be effective. Now, எல்லா ஆன்டிபயோட்டிக் எடுத்துட்டாங்க என்ன இருக்கும் இருக்கிற ஆன்டிபயோட்டிக்ல இன்னொரு 10 வருஷத்துல எல்லாம் தீரும். We do not have any new antibiotic. So the number of drugs if it increases, there is a chances of error that is. So error is of different kind. Let us get into that slowly, and you can just look at this. 2011 there is a global estimate about how much financial burden can be avoided as $500 billion every year. Dollars வந்து accountable தான். Calculate பண்ணாத இந்தியால நிறைய கண்ட்ரில calculate பண்ணினா this would go even very high. So this is a definition given by NCMRP for medical error, and this is algorithm how to categorize the medication error. This is again advanced for you. This is a magnitude of error. I told you, no? This is the recent third leading cause of death in US. I'm talking about the data that are available in US. This is the first one is heart diseases, second one is cancer, third one is medical. So this number has to come down. It has to be eliminated from this top list. So for that we have to work little hard. So we do not have such data from India about what is the magnitude of the medication error. These are the classification. So when we talk about the classification of this error, you can just look at 3 major areas. This is prescribing. Who is involved in prescribing? A doctor would be doing the prescription. please forget about that. The pharmacist prescribing, especially in India, in near future. யாராவது ஃபீல் பண்ணிட்டு இருந்தீங்கன்னா நான் ப்ரிஸ்கிரைப் பண்ணலாம் அப்படின்னு நினைச்சீங்கன்னா பண்ண முடியாது. You can do one thing is you can review the prescription, and if anything is wrong with the prescription, then you can intervene with the prescription. So we are not supposed to even there are different ways that a pharmacist can prescribe, which we are doing illegally. When you go to a pharmacy counter and ask for a medication, he takes and dispenses the medication. So it is his choice of drug and he prescribes the medication. He prescribes, he dispenses. So that way this prescription is illegal. So prescribing is only by a physician or dentist. Certain hospitals permit nurses to prescribe. Doctor ஒரு எமர்ஜென்சிக்கு இந்த மாதிரி ஒரு கண்டிஷன் வந்தா இந்த ட்ரக் எடுத்து கொடுத்துருங்க அப்படின்னு சொல்லுவாங்க. அப்போ வந்து nurses can write a prescription, send it to the pharmacy and can get that. So that is also again approved by the hospital. Otherwise it is not valid. So an error that arises during the process of prescription writing. So before getting into that, I used a term called as pharmaceutical care. A doctor provides medical care, nurses provide nursing care, and a pharmacist is supposed to provide pharmaceutical care. That is very simple. But starting point, end point. Can someone say where exactly pharmaceutical care starts? A pharmaceutical care starts somewhere when the doctor starts writing one medicine for a patient. If we start writing a prescription for one drug, maybe from there I have to seriously look into it. In the partners, the clinical pharmacists, they are being trained for prescription review or medication therapy management. What they do is they go take the medication chart and they look into the drug, whether the given drug is correct, the given drug is appropriate in terms of dose, in terms of route, in terms of frequency of administration. Everything that I have to analyze. If anything is wrong, then I have to go talk to the doctor and try to make it more appropriate. So from there, right, and this is the point where error can occur, is called as administration errors. Who is involved in administration?
Nurses, mostly.
Nurses and one more set of people are there. உங்க வீட்டுல ஒரு யார் அட்மினிஸ்டர் பண்ணுவாங்க? உடம்பு சரியில்லைன்னா அம்மாவோ அப்பாவோ அக்காவோ பாட்டியோ அவங்கள வந்து ஒரு கிளாஸ் ஆகிக்கலாம் patient bystanders. So any error can occur, or sometimes patient by themselves. Patient by themselves, they will do an error. So again, you are responsible for that. And this is exclusively the error made by the pharmacist. You cannot blame anybody else. ஒரு சின்ன கம்ஃபர்ட்டுக்காக you can classify this, and like I say, here doctors are responsible, here patient bystanders or nurses are responsible, here dispensing a pharmacist is responsible. But for me, anywhere any error occurs and the patient is getting the harm, and I feel I would like to take the responsibility, because it is because of the drug the patient is getting affected, and I feel that I have failed in providing my care. When an error occurs in the prescribing stage, it is very well you can notify at the dispensing stage. You can identify the error and you can correct it. Right? And if you do any mistake in dispensing error, definitely that will affect the administration stage. And that you have to prevent it. And when you are doing the dispensing correctly, but still at administration there is an error takes place, then again I want you to take up the blame, because you have not told them about how to take the medications. So the last point of contact before delivering the drug to the patient, that time you can do one process is called as patient counseling or patient education. If you educate them properly, definitely the patient will take the benefit of the drug. So right from that, a doctor starts taking the writing the medication, and patients stop taking medication. Until then, my care has to go. Sir, I am a patient having diabetes. I am a patient having hypertension. So I have to lifelong take my medication. So every day when I take the medication, you have to take care of the patient. Sir, what is that I have given them the right medication, why I have to follow it up if there is any problem associated with the drug. When we talk about error, it is not only the error, there are few other drug related problems associated. There is a possible drug-drug interaction, there is a possible drug-food interaction. Another example, so I can give an example of antacid and ciproflox. Together, if you give, it will form a complex, and the fluorophenols are not available for biological activity. So there is no use in taking a drug together. So only you will be knowing, and you have to tell them how it has to be taken. The same is fluorophenols with food like milk and all, again the same effect. So you have to tell them how to take it. So everywhere, if any ill effect is there to any patient with the respect of drug, then I want the pharmacist to take the responsibility. These are other ways by which you can categorize the medication error. Though I say that the errors are, the system is not much developed in India, but there are many ways by which you can look into it. This is one major category how I classify the medication errors. You can just look into it. This category is not only exclusive for administration, sometimes for omission errors there will be in prescription as well as dispensing error. Unauthorized drugs can be there in both. There could be many reasons. If you ask me to take a seminar on drug error, dispensing error alone, it can take for 2-3 hours. We have so much of information on this, but at least you know what is the categorization of medication error. I don't know, describing a wrong drug, wrong dose, wrong time, wrong indication. The handwriting is not legible, drug name confusion. And one more is inappropriate use of decimals and short forms. Generally, you have been practiced in school mathematics. The 0.2 அப்படிங்கிறது எப்படி எழுதுறீங்க? You have been taught to write it as 0.2. That is applicable here. You should not write 0.2. Sometimes 0.2 can be read as 2. 0.2 milligrams கொடுக்க வேண்டிய இடத்துல if I read it as 2 milligram, that will be an error. So likewise, the Latin terms, you have to, earlier they were using Latin term. Now when we are doing our BPharm program, we had an exclusive chapter on Greek and Latin terms that are used in the prescription. But nowadays the regulations have changed that they wanted to avoid these Greek and Latin terms. Rather, you can tell them directly. Use twice daily. Twice daily na pura tappai. Twice daily na every day is our how to take twice daily medication. Somebody's prescription it is written twice daily. Apna every address கொடுப்பீங்க. Morning and night. அது எப்படி time man? How many numbers that has to, you have to take that and divide with 24. If it is 3 times, 24 divided by 3, 8 hours once. So that timing is very important here. If it is 2 times, every 12 hours. If I take morning 8 o'clock, again the next dose should be taken in the evening 8 o'clock. There may be slight variation for 1 hour plus or minus, but you have to maintain that once a day means the next dose should be given in next 24 hours. நம்ம அப்படிலாம் பண்றது 3 times daily கொடுத்தா என்ன பண்றோம்? டாக்டர் அப்படிதான் சொல்றாரு, காலையில ஒன்று சாப்பிடுங்க, மத்தியானம் ஒன்று சாப்பிடுங்க, நைட் ஒன்று சாப்பிடுங்க. If you look at the time interval, காலையில எத்தனை மணிக்கு சாப்பிடலாம் மெடிசன்? ஒரு பிரேக்ஃபாஸ்ட் சாப்பிட்டா 9 மணிக்கு மெடிசன் சாப்பிடலாமா? மத்தியானம் ஒரு 1:30 மணிக்கு. அப்போ 9 to 1:30 பார்த்தீங்கன்னா ஒரு 4.5 hours. அப்புறம் 1:30 எடுத்த மெடிசன் திருப்பி நைட் எடுக்கணும். நைட் திருப்பி எத்தனை மணிக்கு சாப்பிடணும்? ஒரு 8:30 மணிக்கு சாப்பிடணும். அப்போ அந்த டோஸ் இன்டர்வல் பார்த்தீங்கன்னா இட் இஸ் டிஃபரண்ட். So you have to seriously educate the patient about these wrong timing and all. Same way as dispensing, you can do wrong patient, wrong medication, wrong selection, wrong mixing. This is patient compliance error, where I do not stick on to what is being given to me. I will be taking as I wish. administration error, other types of errors. So you have to give importance. As I told you, in the accreditation era, the NABH standardization has brought the assessment of medication error, which means every month, whatever the number of prescriptions, 20% of the prescription has to be taken, and you have to evaluate the prescriptions for any presence of medication error. There is a procedure by which you will be. So when you start implementing a system into the hospital or your organization, naturally what happens is the number of errors will start coming down. So to meet this challenge, a dedicated position directly responsible and empowered to lead the health system of medication safety strategy and implementation is necessary. And இது எல்லாத்தையும் பண்றதுக்கு ஒரு ஆள் வேணும் அப்படின்னா then probably we will be newly creating a position called as medication safety officer. It is not much happening in Indian setup. We do not exclusively have a medication safety officer, but it is better. Maybe in the last 1 decade, the western part of the world has started looking into these safety procedures and protocols, and exclusively appointing one person, giving him some powers. If something is happening inside person, you will be given with all type of powers. You can go do anything, but I have to cut down the problem. And the way you have to seriously look into the problem, and you have to identify one person who can have control over all these medication safety issues, and he or she will be called as medication safety officer. So, இப்பதான் சார் 10 வருஷமா தான் அங்கெல்லாம் அதை பத்தி பேச ஆரம்பிச்சிருக்காங்க. நம்ம ஊருக்கு இன்னும் 10-15 வருஷத்துல இது இருக்கும். But அது வரைக்கும் if we are not doing all this, no, we are doing, but not in the name of a medication safety officer. Maybe one or other place, or individually as a team or teamwork, we will be doing the role of a safety officer. So we have to stop this kind of errors. So there are ways by which you can prevent the errors, and error strategy prevention is one is by educating the healthcare professionals and the patient. You can minimize the error, and bringing up some kind of procedural practices inside the system, and inducing a newer technology. The western part of the world, because they are more developed. There are robotic arms have been involved in dispensing. When our robotic arms have been involved in doing surgeries. And in our step going, community pharmacy, robots actually started dispensing the medication. In robot, robotic arms, you have to feed them, that will do the process of a pharmacy technician. But again, I am telling you that robot cannot do the work of a pharmacist when it comes to the interface of a patient and a pharmacist. அதுக்கு என்ன ஃபீட் பண்ணிருக்கோமோ அதுக்கான இன்ஸ்ட்ரக்ஷன்ஸ் எல்லாம் அது கொடுக்க முடியும். பட் how to understand a patient, it is only by means of pharmacist. So you can either do the changes in the healthcare providers and patients system, you have to change, and implementing newer technology. When the prescription எழுதும்போது இருக்கக்கூடிய நிறைய associated problems, many times pharmacist cannot or patient cannot understand what the doctor has said. ஒரு காமெடியா ஒரு ஜோக் சொல்லுவாங்க. ஒரு டாக்டர் வந்து கூட ஒர்க் பண்ண நர்ஸ் மேல பயங்கர லவ். உடனே பிரிஸ்கிரிப்ஷன் எடுத்து லவ் லெட்டர் எழுதி நர்ஸ் கிட்ட கொடுத்து நர்ஸ் பிரிச்சு பார்க்கணும் படிச்சா உடனே புரியுது. என்ன பண்ணலாம்னு சொல்லுங்க? நேரா pharmacist போய் என்ன எழுதி படிச்சிடணும். ஆனா there is one person who can read the doctor's handwriting as a pharmacist. அது எப்படின்னா இன்னொரு படத்துல ஏதோ படத்துல விவேக்கோட காமெடி இருக்கும். அந்த விக்ஸ்ங்கிறத அப்படி சுத்தி சுத்தி எழுதியிருக்கோம். அது மாதிரி it is very difficult for one to understand what is written on the prescription. There are a lot of confusions can occur over that. So to prevent this, very simple is you can introduce computer. So computerized prescription ordering. நான் என்ன வேணுமோ அதை டைப் பண்ண போதும். ரொம்ப கிளியரா கேபிட்டல் லெட்டர்ல வாங்கணும், The Medical Council of India already has instructed the doctors not to use brand names, and the name of the drug has to be written only in capital letters. I do not know how many of them really follow it. The public places smoke பண்ணக்கூடாதுன்னு சொல்லியிருக்காங்க அப்படின்னு ஒரு ரூல் இருக்கு இல்லையா, போலீஸ் பிடிச்சாங்க ஃபைன் இருக்கு, ஆனால் பண்ணாமல் இருக்காங்க நினைக்கிறீங்க. எப்பயாவது போலீஸ்க்கு வந்து டைம் வந்து நம்பர் ஆஃப் கேசஸ் கம்மியாக இருந்தால் they will go catch. So we do not really seriously look into it because there are other factors. ஒரு computerized system வாங்கி அதை establish பண்ணணும், அது involve ஆகிற cost that is very high, which is not affordable for us. அந்த காஸ்ட்டை நான் இன்வெஸ்ட் பண்ணணும், யார்கிட்ட கலெக்ட் பண்ணுறது காஸ்ட்? I have to collect it from the patient, and then your system becomes more costlier. But again, to prevent this, I have to do either in these three areas. So there are 10 such strategies which otherwise called as rational drug use. This is applicable for any patient, I mean any healthcare professional. It will be doctor or nurse or pharmacist. You have to first identify the right patient based on the marking of the drug. Always check patient identification, verify patient conditions, and second point is right medication. This is a confusion when there are more number of patients to be taken care by one nurse, and if the medications are placed in the nursing station, they might wrongly administer the drug. இதே வந்து ஒரு ஸ்பெஷல் வார்டு அவங்க ட்ரக் எல்லாம் அங்கேயே இருக்குது அப்படின்னா அந்த கன்ஃபியூஷன்ஸ் may not arise. But there are other mechanisms by which you can come to a conclusion that whether you are administering the right drug. You have barcode systems. இப்போ பெரிய ஹாஸ்பிட்டல்ஸ்லாம் பார்த்தீங்கன்னா பேஷண்ட் உள்ள போனோடனே கையில் ஒரு டேக் கட்டி விட்டுருவாங்க, அந்த டேக்ல ஒரு barcode வரும். ஸோ அதை ஸ்கேன் பண்ணாங்கன்னா அவங்களுடைய டீட்டெயில்ஸ் எல்லாம் வந்து whether they are administering it correctly or not, you can verify with the computer. And if you have an alert system, if something is going wrong, you can easily correct it. So right patient, right medication, followed by right dose. This is again very important for both doctors as well as for nurses. And right time. I will give you example earlier. This is right route of administration. That is also very important. Injection எனக்கு ஊசி குத்துனா வலிக்கும், அதனால அதை உடச்சு அப்படியே வாயில் ஊதிக்கு மசாஜ் அப்படின்னு கேட்டீங்கன்னா it is not right because that is meant for. There is one common thing which always happens in medication is even healthcare professionals like doctors as well as nurses do not understand. You might have heard about coated tablets. Coating is being provided on the tablet in order to prevent it from the environment or to delay the release of the drug. And any of these coated tablets should not be broken. Half tablets are for it. You cannot break it. But that is a very common error you can observe in hospital. Patients will not understand. So it is very important you have to educate the patient for correct way of administration. This happens to right education. This is not very true, but right to refuses. Here I would like to highlight upon the right of the patients. The patient has the right to accept or not. Many times, if you have noticed, if you are in a good hospital where they follow the principles, then they definitely take the consent from the patient before they take it for surgery. If they resist and they cannot, but this is one patient right aspect. So right to refuse, correct assessment, and correct evaluation, and finally right documentation. We lack lot of we are very far behind with many countries like developed countries. The reason is we do not have any documentation. China is far better. We have much better herbal drugs with it, but we have not documented any of this. We have not documented any of the errors that has happened. எத்தனை பேர் உண்மையாவே செத்து போயிட்டாங்க, நான் தப்பா மறந்து போகுது, யாராவது டாக்டர் சொல்லுவாங்கன்னு நினைக்கிறீங்களா? They will never tell. But you have to take those data as guidance, and you have to see that you have to minimize the error. So these are the rights. 7 right to go. You also have made us in right. So medication safety starts with you. Before, what you have understood is what are the problems that the medication can give you. One such problem is medication error. So medication, it starts with you. I am not again saying only this pharmacist, even it is the patient who has to be participate in bringing out the medication safety. So everyone has a role to play in this medication safety. So the need for a leader position to transform the medication safety may be a pharmacist or a clinical pharmacist. Because randomly synonymous we have started using. So pharmacist is the most appropriate or a suitable person who can be termed as a medication safety officer. The reason is very simple. The doctors, they are very busy in providing medical care. The nurses are very busy in taking care of the patients. In another lot of documentation works are being given. And the drug is not taken care. So right time it is the pharmacist who has to take the lead and seriously look into it. That's why I said it is the medication safety officer or a pharmacist. When I am saying a pharmacist is to be the medication safety officer, I am not neglecting or omitting any other healthcare professional. But you being a master's in drug, you know better about the drug. I am feeling that even other pharma professionals feel that a medication safety officer most appropriate would be a pharmacist. So what is a medication safety officer? While the work of medication safety officer is the responsibility to coordinate, to understand, to make a strategic plan, to implement the plan, to evaluate the plan for bringing out the medication safety. So any pharmacist can become a medication safety officer? No. He has to have a list of qualifications, not just by degree, not just by license or by experience. So you need to have very many qualities in order to become a medication safety officer. And even when you have a position as medication safety officer, you will not be permitted to do the action properly. There would be a lot of other systematic restrictions that come in being a medication safety officer. So I can quote one example as employing the medication safety officer at least 20 hours a week. At least 20 hours a week, you can minimize the error from 12 to 40%. 20 hours a week, which means exclusively you have to recruit and give them the insights. நாம பாத்தீங்கன்னா சொல்லலாம்னு தெரியல, பிரின்சிபல் இல்ல, அதான் தைரியமா சொல்லலாம். ஒரு டீச்சர் எடுத்தாங்கன்னா டீச்சர் வேலையை மட்டும் பாக்குறாங்க இல்லையா? அப்ப நிறைய டைம் பாத்தீங்கன்னா கிளாஸுக்கு வர முடியாது, வேற ஏதாவது ஒர்க் கொடுத்து வந்துருவோம். அப்போ ஒரு சின்ன ஃபீல் இருக்கும் இல்லையா? அப்ப டீச்சர் வந்து டீச்சர் வேலையை மட்டும் பண்றது இல்லை. அப்ப அடிஷனலா there are some other role which affects your primary role as a teacher. Understand? இப்போ நம்ம கிளாஸ்லயே எடுத்து பாத்தீங்கன்னா திடீர்னு ஸ்போர்ட்ஸ் வந்துடும், திடீர்னு கல்ச்சுரல்ஸ் வந்துடும், ஸ்டூடெண்ட் வந்து எடுக்க மாட்டாங்க, ஓடி கொடுத்தாகணும், அவங்க ரோல் பண்ண மாட்டாங்க. அந்த மாதிரி you should not restrict medication safety officer. இந்த வேலையை கொடுத்துட்டு வேற வேலையை கையில கொடுத்தா அவரால் you cannot execute the role properly. So you have to exclusively give them the role for medication safety officer. Probably now what we are doing is in developed hospitals, they started having clinical pharmacists. Earlier the pharmacists were doing a service in the system, in the hospital organization. But now when clinical pharmacists have come, it is to the individual patient care started giving, which may reduce the errors. Yeah. The roles of medication safety officer, as per the American system of health system pharmacists, they want the medication safety officer to be a champion who has to be a visible campaigner. When a patient comes to the hospital, he or she has to make sure or advertise that there are provisions are there which takes care of the medication safety, and this is the individual who is responsible for all medication safety. And he should also collect evidences and disseminate his knowledge and skill in all kind of problems that are associated with maybe a clinical pharmacist is now doing when you go to a ward. His activity is not only one reviewing the prescription, he'll be looking into drug interactions, drug food interactions, medication errors, dosage form errors, wrong IV administration. There are many such roles that an individual is doing as a clinical pharmacist. So like that, this particular medication safety officer should be an expert in all kinds of such activities, where he or she should have got experience in that. And he or she should be in a position to develop a strategy, to convince your management. If this is the strategy, then probably I can minimize the drug error, medication error. And I should be in a position to advise. Advise பண்ணும்போது என்ன position இருக்கணும்? You should be in a good position. Then only people can listen to your advice. So the management should see that these support should be given to the medication safety officer. So he also should be a data optimizer. He should be a cross-discipline leader, and whatever the facility that is available to provide medication safety, he should be able to mobilize those strategies. So I don't want to go further into it. If the person is having all this, he or she can be a very good medication safety officer. Again, I recommend with reference to ASSP's recommendation, a pharmacist as a medication safety officer, because he has already played an active role in coaching patients on potential side effects and other medications, and why it is important to take them exactly the prescribed medications. So to improve medication safety, we have to start practicing medication safety practices, where we can find physician, pharmacists, nurses. What they have to do is they have to tell them the patients, like they have to understand the patient, they have to check the factors, and if the data is not available, they have to ask so that the problems can be solved better. And after finding out, these rights have to be taken seriously in prescribing, in dispensing, as well as in administrating. So for a patient, it is very important to understand the medicines prescribed to them. So what they are supposed to do is, again, they have to know the medicine, check whether they have received the same drug that has been prescribed, and any doubt how to take. There is a concept newly being launched. It's called as quality use of medicine. The quality use of medicine, and I get the quality drugs will come into mind. But I am talking about quality use of medicine. How to use the medicine in a correct manner. A simple example is you wear a helmet. அது எப்படி கரெக்டா போடுங்க சார் ஹெல்மெட்? சும்மா தலையில போட்டு போனா போதுமா? You have to buckle it. Right? If you do not buckle it properly, then there is no point in wearing a helmet in case of any adverse effect. The same way, if the drugs are there, if this quality is there, drug is safer. But if you do not know how to use it properly, then probably it is not going to be effective. So patients need to understand their medications properly. And 4 T's again on tell, talk, take, and track. This is applicable for the entire healthcare practitioner team. 5 moments on medication: starting a medication, taking the medication, reviewing, and stopping. It is not that the initial medication. There are few set of drugs which you cannot stop that. You have to taper the doses. Antipsychotic drugs, steroids, stepwise they will increase the dose. After some time, what they do is they will start decreasing the dose stepwise, which means you should not stop taking the medication. So you have to know when to stop, how to stop the medication. This is for patients again. This is already I have told you. So as a responsible healthcare professional, we all have to take pledge
Thank you so much, sir. It is a great pleasure to hear from you, sir. Thank you so much. I cordially invite Mrs. T. Madhavi ma'am, Assistant Professor, Department of Pharmacology, to honor our speaker, Dr. P. Rajalingam sir, Associate Professor, Pharmacy Practice Department, Ramakrishna Institute of Pharmaceutical Sciences, College of Pharmacy, by honoring me short and presenting a memento as a token of love and gratitude. Ma'am, please. Thank you so much, ma'am. I cordially invite Mrs. Gayatri ma'am, Associate Professor, Department of Pharmaceutical Analysis, to honor the chairperson, Mr. L.G. Adil sir, Assistant Professor, PhD College of Pharmacy, Coimbatore. Ma'am, please. Dear delegates, by this we enter the second session of this day. Kindly have lunch and we meet back.